Thank you so much for having me today. A little bit of background. Cardiovascular disease and cancer are the top two leading causes of death in the United States for both men and women. Given our medical advances, many people are living longer, but our elderly population are often afflicted by both cancer as well as heart disease. While cancer therapies such as radiation and chemotherapy can help lead to remission, unfortunately, it can also cause cardiovascular complications. The objective of this talk is to review common causes as well as signs of cancer treatment-associated cardiotoxicities and approaches as to how we can limit these complications. So I'm going to go over two cases with you, and in the back of your mind, I sort of want you to take in some of the information that we're discussing with these cases, and we'll come back to it at the end of the talk. So case number one, this is a 58-year-old woman with a history of breast cancer. She's status post left mastectomy and right prophylactic mastectomy in November of 2017. Her pathology demonstrated that she had invasive ductal carcinoma and was PR positive as well as HER2 positive. The patient started adjuvant doxorubicin therapy for 4 doses. It was later noted that she had a mild reduction in her left ventricular ejection fraction after she received doxorubicin and initial trastuzumab therapy. The troponin was mildly positive and the NT-proBNP was normal. And for those who are not familiar, when I refer to the term the left ventricular ejection fraction, essentially what that is a number, meaning 65% is normal, but also 50 to 65% is low normal. That is actually a reflection of your heart pumping function. And that will play a role when we talk about different types of heart failure. So for this patient, the plan was to continue trastuzumab to complete a year of treatment. So what would you do given the low reduction in her left ventricular ejection fraction is question number one. So for case number two, we have a 77-year-old who came in with a history of cardiac sarcoma in 2012 that was not deemed surgically resectable. This person received mantle radiation as well as the chemo mentioned above. Past medical history was noted for a pulmonary embolism as well as restrictive lung disease. This person presents to clinic with worsening shortness of breath and bilateral transudative pleural effusion. So for this patient, what do you think would be your next steps? So when you think about the different types of cancer treatment, it really does have important complications in regards to your cardiovascular health. So oftentimes what we'll see, unfortunately, from an effect of the treatment, whether that be chemotherapy or radiation, is a list of what I have for you. The number one, oftentimes, of the patients I see tend to have some component of heart failure. Also myocardial ischemia, so meaning a heart attack, hypertension, pulmonary tension, pericardial disease, so meaning that the treatment can affect the muscle of the heart, as well as thromboembolism, meaning a blood clot. QT prolongation and arrhythmias are things that we worry about because that can lead to a life-threatening arrhythmia and cause sudden cardiac death, as well as radiation-induced cardiovascular disease. Often that entails leading to a heart attack. So in regards to heart failure, as many of you know, heart failure is somewhat of a clinical diagnosis. So that could entail someone complaining of shortness of breath, lower extremity edema, weight gain, having difficulty breathing in the middle of the night, noticing that they're having to use a lot of pillows to prop themselves. Those are some of the common signs that patients will complain of. And unfortunately, it can often be related to the chemo treatment that they are receiving. So a list is of the common ones that we tend to see in our practice. I think one that everyone tends to be familiar with is called the anthracyclines, doxorubicin, as well as the alkylating agent, cyclophosphamide. And then there's different ones such as the monoclonal antibody-based tyrosine kinase inhibitors. And then another common one is the proteasome inhibitors. And I will be the first to mention that I'm not an oncologist, I'm a cardiologist. So please forgive me if I'm not pronouncing some of these correctly. I don't use them every day in my practice, so bear with me. Additionally to the chemo, another key aspect is that radiation treatment can cause coronary artery disease as well as a restrictive physiology. And so what this means is that unfortunately, the radiation can kind of escalate your risk of having coronary disease, which one of the ramifications can be a heart attack, and it can also lead to a restrictive physiology, and that would make you more susceptible to having an episode of heart failure. So I sort of went over some of the different types of cancer drugs that are associated with left ventricular dysfunction. So meaning it can affect your heart pumping function and make you more susceptible to having heart failure episodes. And so there's sort of two different types that we sort of think about as a cardiologist, and one being sort of what are the ones that can really lead to permanent damage. So meaning that even if you take away the offending agent, unfortunately the damage is done to the heart, and so there's nothing we can kind of do to help improve that recovery besides trying to get them on the appropriate heart failure medications. And so like I mentioned, the anthracycline tends to be really one of those meds that have a huge effect in causing heart failure. And then the other type is what we say a reversible damage. And so meaning that if you remove the offending agent, so for example, someone who's on trastuzumab, and you notice that there's a decrease in the EF, if you take that out of their regimen for chemo, then typically you do notice an immediate improvement in the ejection fraction. And so those are gonna kind of be two important things that we think about when we're kind of deciding exactly how we can move to the next step to help with the treatment for their heart failure symptoms. The ones that I've highlighted in red in particular are important because we notice that the incidence of heart failure tend to be lower even if you're on these agents, as long as the patient has good blood pressure control. And so for a lot of the patients where, let's say a person was 50 years old and they had a blood pressure of 130/80, I think a lot of people would just say, you can just watch that, you can monitor, you don't necessarily need to be on treatment. But however, for patients who are gonna have that blood pressure and perhaps start doxorubicin, as a cardiologist, we would recommend that they get on some type of blood pressure medication, knowing that the lower the blood pressure is, the less likelihood they are to have an episode of heart failure from the treatment. So this is a table that's sort of showing you the relationship in regards to the cumulative dose of doxorubicin and heart failure. So essentially what I hope that you can take away from this is that the more doxorubicin you have, the increased chance you have of having an episode of heart failure. And so we really want to kind of use the minimal amount that we can get away with for the treatment of the cancer, as well as having a less likelihood to have a heart failure exacerbation. So in regards to the anthracycline cardiotoxicity, so this sort of acute toxicity occurs in less than 1% of patients who are given the anthracycline administration. And it's often characterized where we will see a decrease in the left ventricular ejection fraction. And we can also see some cardiac arrhythmias for patients who are receiving this treatment. The most common cardiac effect is late onset. However, progressive cardiotoxicity has been reported in 3 to 26% of patients, depending on the dose that was given. And like I had mentioned before, really the key point with this is that the anthracycline associated cardiomyopathy is often progressive and irreversible. And so we really want to do the best we can to try to help minimize their potential risk of having a CHF exacerbation. And so anthracycline therapy may initiate a process of injury that can be clinically silent, and then years later, or even decades, we'll then see patients who unfortunately develop signs and symptoms of heart failure. So in regards to sort of the heart failure surveillance and how we can help with prevention, like I had mentioned with some of the medications prior, really focusing on good blood pressure control, especially for those who are receiving a tyrosine kinase inhibitor. Those in particular really need to be aggressive about blood pressure control. Incorporating regular aerobic exercise, which would help obviously with weight management as well as lowering blood pressure. And having a routine assessment of the LV function, which is the ejection fraction, by a 2D echo. What we sort of recommend is every 3 months. And what we're looking for is that from the cardiologist perspective, so I oftentimes read these imaging studies. So essentially an echo is an ultrasound of your heart, and we can assess the changes in myocardial strain pattern, as well as look at sort of the diastology. And those subtle changes can be early predictors as to, hey, later on down the road, this can affect the ejection fraction. So that's sort of how we can really look and see if there's these subtle nuances. And if we're concerned, then we can reach out to the patient's oncologist to say, hey, we're kind of noticing this change compared to 3 months ago, even though the EF is normal. And so the oncologist will oftentimes take that into account and may decide if they need to make an adjustment in regards to the chemo regimen. Also, per our guidelines, it kind of recommends that there should be routine monitoring of cardiac biomarkers, so specifically the troponin and the NT-proBNP. And so what the troponin is it's an assay that sort of shows if you've had stress to your heart, you'll leak this assay. And even for someone who doesn't necessarily have underlying coronary disease, meaning blockages in their heart, this can be mildly elevated because the body is undergoing the stress of the chemo. And as a result, you can see this mild elevation in the troponin. But being able to sort of monitor that as well as the NT-proBNP are subtle ways for us to see what the effect the chemo is having on the heart. And so if you notice a dramatic increase, then those could be subtle signs that, hey, this could eventually have an effect on the ejection fraction. And so what we have noticed is that for when we see the subtleties in the drop in the EF, so if there's a drop in the EF less than 45% for anthracycline or less than 40% for the anti-HER2, then we advise the oncologist to hold that particular chemo drug. So we sort of talked a little bit about some of the cardioprotective strategies, but oftentimes what we sort of say is you want to try to get away with the lowest dose as possible, in particular with the anthracycline class. And for those where we need to do blood pressure control, consider starting a beta blocker. So for example, carvedilol, or an ACE inhibitor like lisinopril, if the patient has a low normal ejection fraction at baseline. And so as a cardiologist, what I sort of classify as low normal is this like 50 to 55%. Remember, keeping in mind that 65% is the normal number that we use. And so, you know, if you notice that there's an increase in the troponin, or if there's a decrease in the myocardial strain, or even a mild drop in the ejection fraction, like 5%, it would be prudent to think about starting either of those medications. Some studies have shown that carvedilol tends to be a little bit better compared to metoprolol, and especially for blood pressure control, you know, with the way that carvedilol works as affecting both two different receptors compared to metoprolol. Carvedilol will have more of an effect on both blood pressure and heart rate compared to metoprolol, which is much better at really dealing with the heart rate issues. Having the combination therapy, you know, a beta blocker and an ACE inhibitor is additive effect. And so the part that is still not quite clear is, you know, there's data that's limited in regards to looking at this because it's all been small trials. But what we can kind of take away from heart failure trials that was dealing with patients who had a moderately reduced ejection fraction, that being on a beta blocker and an ACE inhibitor or an ARB was beneficial to help with the recovery of the heart. And so there's actually another drug that's called dexamethasone, which has been shown to decrease the anthracycline toxicity. So sometimes that's something that the oncologist may give. However, the downside is that it can also decrease the efficacy of the chemo regimen. But that is something that can be used to kind of help minimize the potential risk from the anthracycline toxicity. And this is sort of just a table that's showing you how CoReg, which is carvedilol, reduced the incidence of heart failure events in patients who were receiving both the anthracycline as well as trastuzumab therapy. So kind of shifting gears from talking about heart failure, I'm going to talk a little bit about coronary artery disease or ischemia. Another term you may hear for ischemia is myocardial infarction. Essentially, that means a heart attack. And so what we've noticed is that the radiation and chemotherapies are associated with an accelerated development of coronary artery disease. And the unfortunate part is that the radiation effects on coronary artery disease can be seen very late in presentation. So for some people, we may not see that effect until 40 years after treatment. And so in particular, one of the chemo agents, 5-FU, it has been shown to cause some ECG changes as well as an elevated troponin. And so, especially if you're using a high dose and if it's a continuous infusion. And the reason for these ECG changes and the elevated troponin isn't so much that it's causing a blockage in the heart, but rather it's causing a spasm in the artery of the heart. And so that's what can kind of disrupt and cause injury to that artery. And there's also a small incidence of this occurring with the agents, paclitaxel and its similar counterpart. And so for patients who are going to be receiving high doses of like 5-FU, we do recommend an ischemic evaluation prior to initiation of that therapy for high-risk patients. And when I say ischemic evaluation, essentially a stress test. And it can be something that's like a simple stress test on the treadmill, gives you pertinent information, and that's something that we routinely use in our clinic. So one of the cardiovascular risk factors that we all know is hypertension. And in particular with certain agents, there's a much greater link with increasing blood pressure. And those are the ones that I have listed in here. The incidence for the VEGF signaling inhibitors is quite high of leading to hypertension. So you want to be very aggressive with blood pressure control. Same with the proteasome inhibitor as well. And usually what we recommend is that one agent will not really do the trick, and it is better to have two different agents from two different classes. So again, sort of going back to, you can use the beta blocker and the ACE inhibitor, but usually that's kind of what our first go-to is for the medications. But using a calcium channel blocker like amlodipine would be fine as well. And the reason why we're aiming for a good blood pressure control is, again, to prevent the incidence of having a heart failure exacerbation. So another thing that we see is pericardial disease. And what that means is that the chemo or radiation can affect the muscle in the heart, and it can also lead to fluid around the heart. And that is what's called pericardial effusion, which can affect 5 to 15% of patients with late stage cancer, particularly if they have evidence of metastatic cancer disease. And here's a list of the chemo regimens that are oftentimes associated with pericardial effusion. And then radiation can also affect the pericardial muscle and lead to what's called like a constrictive restrictive physiology. And essentially what that means is that it can affect the heart to lead to a heart failure episode. Switching gears, we kind of went through some of the cardiovascular effects that the chemo can have, but oftentimes we sort of forget about thrombosis or embolism. So having blood clots is definitely a high risk that can happen with any cancer patient, but especially even with certain chemo regimens. And so if for some reason someone was to develop a embolism in their lungs called a pulmonary embolism, or a blood clot in their legs called deep venous thrombosis, then usually what is preferred by both oncologists as well as cardiologists is to use low molecular weight heparin. And then you can also use sort of the newer oral agents at the discretion of your oncologist. For example, Xarelto, which is rivaroxaban, or Pixaban, which is Eliquis. So the arrhythmias that we worry about in particular is something that's called QT prolongation, and that's associated with arsenic trioxide as well as the tyrosine kinase inhibitors. And what happens if your QTc is prolonged is that it can lead to a life-threatening arrhythmia called torsades de pointe, and that can lead to kind of a sudden cardiac death or a VFib arrest. And so we really want to kind of be careful of patients who are on that regimen, as well as taking other medications that are known to prolong the QT. For example, commonly prescribed antiemetics like Zofran, antibiotics like azithromycin. You kind of want to be careful with certain things if they're on this particular type of regimen. And the incidence of ventricular tachycardia or ventricular fibrillary arrest increases up to tenfold with cancer diagnosis, particularly if they're along stage 4 of their disease. And something that we've oftentimes dealt with on the cardiology service is the prevalence of atrial fibrillation. And so that dramatically increases once you have, unfortunately, diagnosis of cancer. And the AFib can also be increased with certain chemo drugs as well. So that's just something to kind of be on the lookout for. So one of the things that, we've spent time talking about is what are the medications that we can do to kind of help combat some of the toxicities from the chemotherapy in regards to the cardiovascular system. But one of the things I definitely want to highlight is a program called Cardio-Oncology Rehabilitation. And so in our program, what we have is something called Steps to Wellness, which many of you may have heard of. But the part of this is to improve the quality of life and kind of think of new solutions to address cancer-specific cardiovascular risk reduction. And so the way that this program was built about was based on the traditional program of cardiac rehabilitation, which is a program that focuses on 2 different aspects. One being the education piece, kind of giving counseling about how to implement lifestyle changes and behaviors to reduce cardiovascular disease, and the other part being exercise, where it's geared specifically towards what the patient can do and trying to build upon that to help improve their deconditioning that they often have from their chemo or radiation treatment and help get them back to their baseline of what they were previously. And so I think what's nice is that this really offers a multimodality way to incorporate both exercise as well as counseling. It really allows for those who have cardiovascular risk factors to try to help minimize that by monitoring blood pressure, weight loss, and so forth. So going back to case number 1. So like I had mentioned, we had a 58-year-old who had breast cancer and a mild reduction in her EF after she was given both doxorubicin and trastuzumab. And so, when you're thinking about, okay, here's this person, it's a slow drop in the EF, what should we do? So one option would be that you can continue with the trastuzumab and stop if the EF was to get lower and drop more than 10%. Another alternative is that you could just discontinue and monitor for reoccurrence, or you totally shift gears and employ a totally different strategy. So sort of think about what you think you might do just based on what we had talked about. So for this patient, what we ended up doing was we started her on carvedilol and lisinopril, and we opted to continue the trastuzumab therapy. And then, like I mentioned before, checking a troponin as well as the NT-proBNP are ways to kind of see how the patient is responding and to monitor. And so those were checked monthly. And then a limited echo was done 2 months. But like I said, it varies. You can do every 2 to 3 months is fine. So for case number 2, remember we had a 77-year-old who had the history of cardiac sarcoma, had done radiation, and he's coming into your office complaining of shortness of breath as well as having recurrent pleural effusions. So what should we do next? So you sort of want to think about with his presentation, what could be the cause? And so obviously, heart failure is one of them. With the pleural effusions, this person could be having a recurrent pulmonary embolism. The radiation itself can cause damage, so you want to think about lung injury, coronary artery disease. It can also cause valvular heart disease, which we didn't spend too much time of, but again, just having that direct contact can really affect the structure of the heart. And then it can also cause this constrictive, restrictive physiology, which essentially results in heart failure exacerbations. So kind of think what you would want to do for this patient. So what we opted to do was to do a thoracentesis, hoping that if we were to tap the fluid in the lungs, that would help provide some relief for the patient. But unfortunately, it came back and the patient was still having shortness of breath. And so at that point, if they're still having symptoms, you can't say for certain that it's not due to like angina, meaning that it's not from coronary artery disease, or if it's from the lungs. And so it would be reasonable to go ahead and check pulmonary function tests and do what's called a left and right heart catheterization as sort of the gold standard to see if there's any issues going on with the heart, to rule out ischemia, so meaning blockages in the heart, as well as pulmonary hypertension. So this is a great article for people who are sort of interested in wanting to learn more. It was taken from the Journal of American College of Cardiology, and it has a very nice state-of-the-art sort of review about cardio-oncology. So what are sort of the cardiovascular manifestations from chemo and radiation? And so it's essentially highlighting sort of what we had talked about, but it's a great sort of quick resource that you can look at. And so, especially for cancer patients in particular who already have heart disease, I think it's very much reasonable to sort of go into this as a tag team approach of getting cardiology as well as oncology on board to kind of risk stratify, what are the potential issues that this patient may encounter depending on the type of chemo regimen that they're going to be receiving. And so like we had talked about, for some of the chemos like anthracycline, you can think about trying to get away with dose reduction using dexrazoxane, and also using a liposomal doxorubicin can really kind of help minimize the risk of cardiotoxicity. Trying to avoid anthracycline with trastuzumab would be helpful as well. And then with the VSP inhibitors, you really want to aim for good blood pressure control. And so when we're thinking about when we notice that there's a mild drop in the EF or a change in the strain or increase in like the troponin, the lab work, so forth, definitely think about starting a beta blocker or an ACE inhibitor. And then if you notice that there's a dramatic reduction in the EF, less than 45% for the anthracycline or less than 40% for the trastuzumab, then you want to hold that offending agent and speak with the oncologist. And if there's certain signs or symptoms that are concerning for a heart attack, that's when you can kind of reassess if you need to do a stress test or going directly with a cardiac catheterization. And so those types of treatments should never really be withheld for a patient who is undergoing treatment for their cancer, but rather is just risk stratifying what would be in their best treatment for them. And then this next slide, again, is just sort of highlighting what we kind of discussed, but it's a little bit easier for you to see visually of the different cardiovascular complications that can occur and sort of what we can help do to minimize and mitigate that particular risk. And so with that, I will take any questions. If anybody has anything that they would like me to discuss further, or if there was something that they weren't clear about. Thank you so much for your time.